so much for joining us for tonight's webinar. My name is Emily Springer. I'm an academic trainer in the Center for Teaching and Learning, and we are thrilled to be able to support our School of Health Sciences in their webinar series. Just a couple of very brief housekeeping things. We are recording this webinar, and it will be located in our CTL LibGuides webinar page about 24 hours after our live session. I'd like to invite you to participate in the chat, ask questions in the Q&A, and if you would like to see the scrolling subtitles of our webinar this evening, you can hover over the bottom of your Zoom, select the show subtitle option, should you like to view that as we continue our presentation here. Without further ado, just a friendly reminder to make sure you are muted if you are not speaking this evening. And I am going to pass this over to one of our very own students, Veronica Shake.
Hi, thank you, Emily. So we wanted to welcome you all. My name is Veronica Shake, and I am in the Master's, the MSN Management and Organizational Leadership program. And so we wanted to welcome you to our March Interprofessional Education Seminar Series. Tonight's speaker, I'm super excited. It's Dr. Seymour, so I will be introducing her shortly. Looking ahead to the next month, we have Ann Rhoda, Vice President of Mission Integration and Spiritual Care of Adventist Healthcare, coming to talk to us about the role of spirituality and our human connection. So we invite you to come back and visit us again in April, April 28th. For those who have missed speakers from prior months, or if you want to revisit them, then like Emily said, the recording of the presentation will be available in the Commons. So now it is my privilege to introduce Dr. Seymour. Barbara Seymour, Doctor of Nursing Practice, Registered Nurse, Nurse Executive Board Certified, and Certified Professional in Patient Safety, has over 20 years of healthcare experience in clinical practice and nursing leadership. She began her career in Louisville, Kentucky, where she completed her bachelor's degree and worked in a variety of settings in the cardiovascular service line. Her leadership roles include critical care, surgical services, and since 2013, executive leadership in both community and tertiary hospital settings. Barbara earned her doctoral degree from the University of Central Florida in 2019 with a focus in executive leadership. Barbara is passionate about using stories to connect people to purpose and drive high-quality, patient-centered care that helps make communities healthier. Additionally, Dr. Seymour is one of the best mentors a person could wish for, and I've learned a ton from her, so I look forward to us getting to learn from her even more tonight. If you have any questions, like Emily said, please put them in the chat, and we will address as many as we can at the end of the presentation. I now turn the time over to Dr. Seymour for her presentation on health system interprofessional collaboration, executive insights from a chief nursing officer perspective. So Dr. Seymour.
Thank you, Veronica, and thank you for the lovely introduction. I'm really excited to be spending the evening with you tonight. I will warn you, you can see on my title slide, Interprofessional Collaboration, Who Wins the Super Bowl? Anyone who has worked with me previously or currently will tell you that, as Veronica said, I love to use stories and analogies to help us better understand what we do in healthcare. I feel like sometimes we get so entrenched in what we do and a little bit nose blind in our own business that sometimes it's helpful to step outside of our own circumstances and use what happens in the world around us to better understand. That being said, I know very little about football, so this may be painful for those of you that do know things about football. So I will apologize in advance, but I hope that we will have a good time this evening talking about interprofessional collaboration. You can go to the next slide, Veronica. So tonight we're going to spend some time talking about some components and characteristics of an interprofessional team. Just really talk about how we work together to drive quality improvement, talk about some measures of success, and draw some parallels to implement those things in other interprofessional teams. You can go to the next slide. So Veronica asked me quite a while ago, before the Super Bowl, obviously, to prepare for this evening's presentation. And as I was thinking about how I wanted to share some of my insights from my own job and how I've worked with interprofessional teams, a fascinating parallel occurred to me the Monday after the Super Bowl. And I started to think about who wins the Super Bowl. It may seem like an obvious answer, but I was curious. So out of that curiosity, I decided to Google search 2022 Super Bowl champions. And this is the first picture that appeared. I don't know if anyone knows who this is. I did not know who this is. And knowing nothing about football, or really just enough to be dangerous, I assumed this was the quarterback of the Los Angeles Rams, but it is not. So immediately I had a bias that was exposed in trying to understand who wins the Super Bowl. And then I wondered, well, was he the MVP of the game? And no, he was not. So there was bias number 2. So I remained curious as to the question, who wins the Super Bowl? You can go to the next slide. So out of that curiosity, I Googled Los Angeles Rams, and there he is again at the front of the team. This player is clearly important to the team. He's not the quarterback. But you also have to recognize that even though this player is important, there is a huge team that is following behind him. And again, some folks may know who number 99 is, but I still have no idea. And I don't know who any of those people are behind him. So I'm still curious who wins the Super Bowl. You can go to the next slide. So this is obviously a host of fans dressed in their gear, braving the crowd, which I think is especially brave considering the pandemic, spending a lot of money for what will most likely be a once-in-a-lifetime experience for these folks. And it made me wonder, are they the people that really win the Super Bowl? You can go to the next slide. So here is my vast knowledge of football summarized into one slide. And in full transparency, I had to look up most of this information. But when you look up football, it is defined as a collection of team personnel, including football players, the head coach, coordinators, and more. The players play, the coaches and coordinators stand on the sideline and they give players instructions. And then the team is subdivided into 3 units: the offensive team, the defensive team, and special teams. So I kind of want to have you keep this tucked in the back of your mind, thinking about this collection of teams and coaches and individual players and subspecialty teams, all working towards a collective purpose and a common goal or mission. You can go to the next slide. So back to the original question, but we're going to think about it in terms of healthcare. Who wins in healthcare? So this is a picture of me with some of the nursing staff and students, although if you Google LifePoint or Sova Health Martinsville, you will not see my picture as the first thing that comes up, like number 99 for the Los Angeles Rams, and that is a good thing. But when we think about hospitals, they exist to provide nursing care, treatment, and services. So does nursing win in healthcare? Are we the MVPs of acute care? So there's bias number 1 that kind of comes to the forefront of how we think about who wins in healthcare. Next slide, please. So this is a picture of several of the members of our team at the hospital. You'll see people from plant operations, environmental services, social work, respiratory therapy. This was actually about a year ago. Little trivia about where we live. We have a NASCAR track that is in our town. And so when NASCAR was in town for the race, they did a parade for us with the big car hauler and some of the drivers. And so this is a lot of the team that was standing outside to enjoy that with the NASCAR folks. So you can see a big part of the team lined up with us to quote unquote take the field of healthcare. So are they the people that really win the Super Bowl in healthcare? You can go to the next slide. So this is not a fan like we would think about Super Bowl fans, but this is a boy named Corey. And when I met him, He was dressed in his gown, braving the hospital, spending a lot of money for what was the final experience of his short lifetime. So do patients win in the healthcare experience? You can go to the next slide. So when we think about the parallels between healthcare and football, and again, thank you for bearing with me through all of that. Healthcare is really a collection of team personnel, including nurses, administrators, and many other folks. Healthcare professionals deliver care. Administrators, in some cases, but to a little bit of a degree, stand on the sidelines and give healthcare professionals instructions on how we need to play the game. And there are multiple specialty teams in healthcare: nursing, respiratory therapy, environmental services, dietary, physical therapy, social work. We could sit here for the rest of the hour and talk about all of the teams that participate in healthcare. But healthcare is made up of staff and leaders, subdivided into those specialty teams, made up of individual employees, and each with an individual job, a collective purpose, and a common goal or mission. So healthcare might be a little more like football than we would realize. You can go to the next slide. So we come back to Corey, the boy on the bed. When I met Corey, he was a patient in my hospital, and I became friends with Corey's mother, and am friends with Corey's mother to this day. Corey had had an accident and a back injury. And because of that back injury and some surgeries, required some pain medication after his initial discharge from the hospital. And for Corey, that introduction to opioids as an opioid naive patient, very young, became a gateway for him to participate in drug use. Corey was a sweet young man. He held a job. He loved his sister and his niece and his mom and his dogs and cats. And so when we think about drug abuse issues, we tend to have a bias in our mind about the people that participate in that. And Corey is certainly not what you would think of in your mind when you think of drug abuse issues. And so his journey from that initial surgery to addiction, unfortunately, led him to a place where he had destroyed one of his heart valves. He had had that valve replaced, and unfortunately was unable to break his addictive cycle.
He's only going to make what they're paying him, which I would
Just a friendly reminder for those of you who have joined us to please mute yourself.
I would agree.
Oh.
We're all set. It looks like I found it and was able to mute. Thank you.
Okay, thank you. So Corey unfortunately succumbed related to his valvular disease and died at a very young age. And I'll share with you at the end of the presentation a beautiful tribute that Corey's mother made to the healthcare team. But, you know, Corey's story is certainly one that is deserving of sharing because it really helps illuminate a particular instance where the interprofessional team is impacted by a single patient or a patient population, and we have an opportunity to do things better together as a team. You can go to the next slide. So I want to preface this slide by saying I'm not an expert in the field of pain management, but I do think that this is an opportunity for us as individuals and members of the collective healthcare team to talk about how we recognize problems, how we think about and collaborate on how we may improve outcomes related to those problems, how we develop and implement plans, and how we evaluate the success of those plans. And so I want to talk a little bit about pain because it's something that we are focusing on as an interprofessional team in my facility in an area that has a very high drug addiction rate. And so when we think about pain, it is a pandemic, endemic type of issue. Pain impacts millions of Americans. And despite sorry, I'm having trouble reading all of a sudden, increased use and availability of those medications, more than 80% of patients that are hospitalized feel like they don't have adequate pain control. So we have these pharmaceuticals available, yet we're still not meeting the goal of therapy with those patients. It's a significant public health problem, and it impacts a large number of people, not only in its acute phase, but in its chronic use as well. You can go to the next slide. So when we talk about pain on a national scale, in 2019, over 70,000 drug overdose deaths occurred in the United States, which is a 4% increase in 1 year. And opioids are the main driver of drug overdose deaths in the United States. Also, when you think about month over month increases, there was a 47,000 death increase in single months at times. You can go to the next slide. When I think about what happens locally for the patients in the communities that we serve, in Virginia, the number of drug overdose deaths nearly tripled from 2015 to 2021. And over 80% of those drug-related deaths were attributable to opioids. You can go to the next slide. So how do people get their hands on opioids? And often it's the same types of issues that Corey faced, surgical procedures, dental procedures. We introduce pain medications and opioids to patients who are opioid naive, and it creates issues for them that they carry. Opioid prescribing peaked in 2011, so we are seeing some downward trend in prescribing practices. But it's still at a rate 3 times higher than in 1999. So we still have some ground that we need to cover in reducing opioid prescribing. You can go to the next slide. So as an interprofessional team, we really need to come together and think about how do we effectively manage and support patients with pain? And as I go through these questions, I want you to think about people that are not just nurses, even not just physical therapists or social workers. I think when we think about pain, you have an automatic thought of who can help alleviate pain and suffering. But I can tell you from my own experiences with my dad in the hospital, oftentimes it was someone that came in to clean his room that took the time to talk to him and hold his hand and give him some distraction that helped him with his pain. So I'm going to challenge us kind of to the point of our conversation tonight to really think about what members of the interprofessional team participate in caring for our patients with pain. So how do we effectively manage and support patients with pain? How do we understand the full range of treatment options available, which can include opioids, but doesn't have to? How do we create holistic approaches to pain management? And how do we create meaningful goals for pain management and not pain elimination? You can go to the next slide. So when I think about Corey and his experience, obviously Corey and his mom were impacted by his experience, but I can tell you there were multiple members of the interprofessional team that were changed by their experience with Corey, being exposed to his story, watching him suffer, and feeling helpless or less than empowered to be able to do anything to help him. I think oftentimes we identify a problem, but we don't always understand how we come together to identify that common goal and work as an interprofessional team to make that better. So you can see the key stakeholders in pain management. I've made that bi-directional on purpose because family and nurses and providers and physical therapists and pharmacists and a whole host of other special teams impacted Corey in his pain experience But Corey, in turn, impacted the interprofessional team and their care delivery experience. And we need to understand those stories and use those to help us identify those problems and to drive us to make care better for the communities that we serve. You can go to the next slide. So when we talk about why do we focus on pain, and you can put a blank in there for pain, and you can start to think about all of the other problems that we have in terms of how we care for our communities. Why do patients fall? Why do patients have to go to subacute care facilities? Why can't I wean my patients from oxygen? And these are all questions that really require the focus of people outside of nursing, those people on the interprofessional team, to help us understand those things and answer those questions. And so when we talk about pain, or really anything that we're working to improve, we need to think about how do we understand if we're making things better. And so the only way we can do that is to have some type of baseline measurement, implement a plan, and then evaluate that measurement to see if it is improved in the way that we suspected that it would. So on our own campus, we're getting ready to implement a multimodal pain management order set. And this involves the pharmacist, it involves physical therapy, it involves social work, it involves nursing, it involves providers. We are taking an approach where we will be educating everyone about multimodal pain management, because everyone that goes into a patient room can impact pain and suffering in a positive way. That being said, how do we understand if we're making a difference or not? And so we're working to collect some baseline information on morphine equivalents, patients' perception of pain, but also staff satisfaction and perception of patient pain. One of the things that we've talked about as an interprofessional team is, what if I'm not able to make my patients comfortable? What if we're not able to make a meaningful goal for pain management, but not pain elimination? And so there's anxiety on the part of the interprofessional team on, if we make this change, not only how will it impact patients, but how will it impact me in my care delivery? We always need to think about moral distress for our staff as well when we implement actions like this, and make sure that we've safeguarded and given them the tools to understand that we don't want to add any burden to their work or to them in terms of moral injury by putting them in a place where they feel like they can't provide the best care for their patients. And so these will be our baseline measures of success. And we will measure those throughout the launch of our multimodal pain order set to understand if we're making a difference as an interprofessional team. You can go to the next slide. So I always come back to the story whenever I talk to a group, and I have lots of stories. My poor team has heard stories about my daughter playing volleyball and my son in ROTC and my dad and our own experience in healthcare. And I'm really grateful to Kathy for giving me permission to share Corey's story tonight as part of what we talk about with interprofessional collaboration. So I want to come back to Corey and want to talk about, how do we measure who wins in healthcare? Who wins the healthcare Super Bowl? So we have global subjective measures in healthcare like CMS ratings, star ratings, leapfrog grades. And I think if you think about those things in terms of how we measure success, then you would say that's the equivalent of the Los Angeles Rams winning the Super Bowl. That's the team, how we collectively measure success. We have facility-based objective measures, and sometimes even unit-based objective measures, like quality scorecards and engagement surveys and HSOP scores and P&L spreadsheets if you're talking about the finance part of healthcare. And sometimes some departments are wildly successful, and sometimes some departments take a little longer to catch up. So sometimes there's an MVP that wins the Super Bowl. if we think about it in terms of individual departments or even different interprofessional teams. We have letters from patients and families. We have flowers and candies and donations. And sometimes at the individual level, it's just the lasting memory of holding the hand of the boy in the bed or his mom. Sometimes, regardless of the outcome, the patients win the Super Bowl. And really, that's what I want to leave you with tonight as we think about Corey. That's ultimately our charge as an interprofessional team, whether we're talking about pain or fall risk or infection or patient satisfaction. It's to ensure that our common goal is to continually humanize the care experience as an interprofessional team and be sure that ultimately at the end of the day, outside of star ratings or quality dashboards, that we are a team that plays for our fans, our patients, and for the boy in the bed. You can go to the next slide. So again, I want to thank Kathy Taylor, Corey's mom, for allowing me to share his story. If you'd like to experience her thoughts and her grief and her appreciation, in 2016, and some of you may have seen it, there was a video that came out during Nurses Week, and it's called It's a Nurse. You can Google it and it will take you to the YouTube video. It's a letter that Kathy wrote to the hospital after Corey's passing to express her gratitude. And while it's titled It's a Nurse, and Kathy talks a lot about the nurse's role in Corey's care, we all understand that that could never have happened without the support of an interprofessional team to make sure that we were doing everything that we could to provide the best care for Corey in his final days, and for Kathy as she was with him. You can go to the next slide. So I thank you for your time this evening and for allowing me to, have some time to share with you some of my experiences, my horrible analogy to football. Again, I apologize for you football fans. And to be able to share with you Corey's story and to hopefully bring you closer to the human experience of patient care as an interprofessional team this evening.
Well, we super appreciate Dr. Seymour's your presentation and for your explanation on pain management and the patient and how it's not just one person that wins the Super Bowl, or it's not just one person that wins the patient care experience, it's the whole team and how they work together in order to facilitate this. Are there any questions? Anybody in the chat? If you have any questions, please feel free to put them in at this time.
And as we wait, Veronica, if it's okay, Dr. Seymour, did you have a reference slide that you would like to show in the recording so we can stop sharing my screen?
Yes, please. Thank you for the reminder.
Okay. Just want to make sure people are able to grab that while our attendees are popping in questions in the chat or the Q&A. And I will go to the last reference slide as well too. Okay. Just want to make sure if anyone wants to get a screenshot of that, they're able to at a later time. And can I stop sharing my screen at this time?
Ma'am, thank you.
Great.
So one of the questions, Dr. Seymour, if you can share, as a leader in this in your position, what strategies do you consider to help promote an environment that works with teamwork and creates this capacity to collaborate?
So a couple of things come to mind. I know as leaders, we need to be visible and accessible. When I talk to nursing students and new folks that are joining our team, I'll tell them, I'll look down, and usually this is the case. I rarely wear a skirt in Virginia because frankly, it's just cold after living in Florida, even in the summertime. But I'll look down and I'll kind of tug at my pants leg and I'll say, do you see my pants? And people just kind of look at me kind of funny. And I say, I put them on one leg at a time, just like you did this morning. There's no great and powerful Oz that's behind a curtain somewhere. We are people that are interested in advancing care for our community, just like you are. And so I think having those conversations and being visible and accessible is very important. The other fundamental thing that we are charged with is making sure that the voice of our staff is heard and that they are involved in everything that we do to promote quality care and process improvement. And so one of the things that we have done very recently in my facility is launch daily measures of success, where we talk about an outcome goal. What do we do in our day-to-day work that we think drives that outcome? And so we measure that every day. There's a place for the staff to write what gets in their way. Why can't we get that done? And so we work to remove those barriers that they have identified so that we can help them win the day every single day. What I think is particularly interesting for nurses is that it seems like a foreign concept when you talk about process improvement, when you relate it to quality outcomes or customer experience outcomes. Oftentimes folks will say, I just really don't know how to do process improvement. I consider my job as critical care nursing for the organization. It is my job to assess what's happening in my building, diagnose problems. I need to understand if I make a change in one area, what that's going to do to other systems that are within the hospital. I make a plan that I think is going to impact that in a positive way. I implement that plan and I evaluate the outcome. That is nursing process. And so I think when we launch this and we give some parallels, like let's talk about high blood pressure, let's talk about high blood sugar, and do those side by side with process improvement. It's so fun to see that light bulb moment for nurses, like, oh, I really do know how to do this. And then they start to get involved in identifying those barriers and making plans to improve. And once you have that staff engagement and participation, you are off to the races and you do some amazing things. And the staff is so excited that they feel like their voice is heard and they can see the fruit of that labor in the day-to-day.
Dr. Seymour, I have an observation and a question. So first and foremost, thank you so much for telling a story. Given the work that we often do, I think we at times may lose the fabric of the stories and the pace with which we work. So anytime that we can get into a space and a place to really just appreciate the human aspects of what it is we do alongside our colleagues every day, I think is a celebration unto itself. My question to you is, at the top of your presentation, you spoke about bias as you were looking at the players coming out. And just a tidbit, for those of you who don't know, like the offensive line is often described as the foundation for a successful NFL team, because without a sound offensive line, the quarterback is not protected, the ball is at risk, and there goes all of the opportunities to score. So those often unsung heroes are members of that offensive line. But getting back to my thought about the bias, the question that I have for you is, did you have any observations about different types of bias that occurred throughout your journey caring for him, and just having to help each other address the different origins of their bias, and how did that look across the different team members?
Yeah, I think in Corey's case in particular, that initial bias emerged very early in his care journey. And I think we would probably all, a little bit to our shame, admit that when you say drug abuser, you get an instant image in your mind. And so there were some thoughts and speculation about Corey's journey, and the word drug abuser seemed to be dirty, but I will tell you, Kathy advocated so strongly for him and was so adamant about sharing his story with everyone that touched him, that they became like family. As you can imagine, he stayed with us for a very long time. And so that power of sharing stories, to the point of your observation, really helped to combat that bias where Corey was concerned, and helped us think about drug abuse in a way where we really tried to think about root cause. So for the next patient that was not a drug abuser, but maybe was opioid naive, how do I prevent someone from being in the place where they're having to tell another story like Corey's? So I think that was probably the most impactful bias that was changed related to Corey's particular case, and how we were able to implement change to hopefully prevent others from having that same type of experience.
Thank you for that question, and thank you for that answer. We had another question in the chat going back to your daily measures of success. What do you use to evaluate the issues in your processes, or how do you evaluate or what objectives or what standards do you use to help facilitate evaluation, making sure that you're meeting your marks and all of those things?
So it may be helpful to give a specific example here. One of the issues that we're facing is a high number of falls. And this is one that I'm particularly passionate about because my dad had a brain tumor. I'll save his story for another time, but he fell a lot. And so I'm very passionate about falls reduction for a lot of different reasons. But we really looked at our fall rate and tried to understand what are the contributing factors to a high number of falls. So when you ask that question of the staff, usually their initial reaction is, we don't have enough people to prevent falls. But you got to get past that uncomfortable place and dig a little bit deeper to understand, are there any other commonalities that we need to address? So we started with assessment. We did a risk analysis of our patient falls to understand, were there any commonalities? Did we have any gaps in our process? We shored up our process based on the most current evidence. And then we looked at those trends, and what we found was a high number of our patient falls were with patients that had an extended length of stay and had not been mobilized during that length of stay. So using that information with the highest commonality, we worked together to develop what we affectionately call the Breakfast Club. So I don't know if anybody's old enough to know the movie, but if you do, it's a little bit cheesy. But anyway, so the goal of the Breakfast Club is to have as many patients as we can out of bed to the chair before their breakfast is served. And that helped increase mobilization. Once patients were up to the chair, we found that they stayed in the chair for a longer period of time than we would anticipate. And we wanted to understand, is that going to help decrease our number of falls? So we use the Breakfast Club as our daily measure of success, and we have a goal for 50% of our patients to be out of bed for breakfast. And we say by 10 o'clock in the morning, just in case it's a particularly busy day. And so every day I will round and I will see how many patients are out of bed for breakfast. And we track that on a simple graph that's displayed publicly in the unit. I have told the staff I want that to be the ugliest board that there is, because if it's ugly, it means there's a ton of people writing on it. There's different colors, but to me, it's beautiful because it means that people are using the board. And so it's simply, you put a dot for the percentage and we connect the dots over the course of time. That becomes powerful though when we do our safety briefs in the morning at the change of shift. We have both sides of the clock there. And so we look at the graph, and in this particular example, if it's above 50%, we say we got, I'll just use an arbitrary number, 60% of our patients out of bed before 10 o'clock yesterday. We celebrate that success, and then we ask, what happened yesterday that we can replicate today to make sure that we win the day? On the other side of that, if we're below that 50% goal, we say we only had 40% of our patients out of bed before 10 o'clock yesterday. What was the barrier? And what can we do more, better, or differently today to win the day? And that gives the staff the opportunity to say, well, here's what we did that worked really well. Let's try that again today. And it generates that excitement. Or on the other side, they talk about, well, we had this barrier or that barrier. This is something that we can impact today to hopefully meet the goal today. I will tell you, when we started this, we set an initial goal of 35% of our patients out of bed. We blew through that very quickly. So we set a secondary goal of 50% of our patients out of bed. And in this month on the 5th floor, they have achieved 80% of their patients out of bed by 10 o'clock in the morning. At the same time, we have had a 60% reduction in our fall rate over the course of the year since we implemented the Breakfast Club. And that is huge for them. We always tie back to, this is what we have been able to do collectively as a team to impact patient safety. And especially in this community, this is a very small community where they are truly taking care of friends, family, and neighbors. I can look at my staff roster and see the same last names that I see on my patient list. And so that really hits home for this staff, because there are so many times that it is somebody's neighbor, aunt, mom, sister that is in our beds. And so they are highly invested in making sure that we are doing everything we can to keep their friends, family, and neighbors safe.
Thank you. And that idea of the visualization of not only your barriers, but also your successes, how to hold people accountable, but also to celebrate those wins, and looking at both sides of that, that's a fantastic thing. One more question, or another question is, how can we improve our student experience to include daily interprofessional collaboration at the executive leader level to support patient care?
That's a really great question. I think, to set that expectation with students, and I'm going to brag on Veronica here for a moment. One of the things I love about Veronica is, as a student, she holds me accountable in the same way that I help her learn and grow. And so I think that, with the student experience, if you can tell them this is what you want to see in your facility or your mentor, and you ask for that and you go for it, and then let them hold us accountable, because we need that fresh perspective as well. To me, it's one of the things I appreciate the most about the students, and especially Veronica and what she does for me. And so, for us, I think that goes both ways. I'm happy to invest in her experience, but it's been just as enriching and rewarding for me on the flip side of that. So I would say set the bar high and tell the students to go for it.
Oh, thank you. And yeah, Dr. Seymour, it's really helpful when you have a mentor when you're invested and your mentor is invested. So I always love, I brag on Dr. Seymour as well, and I always love my interactions with her. So Deborah, I think you had a question.
I do. Another question. So you were talking about how intimately involved the community is merely by the size of the area and people caring for family, and how important that is. Can you share with us how you've actually engaged family members into interprofessional committees or performance improvement committees or efforts like that to influence your quality of care and general outcomes?
Sure. And I'm going to talk a little bit about here, but I'm also going to talk a little bit about past experience. We definitely have strong community participation. For example, we had our market quality meeting today, and we have 3 community members that participate in that. So they see our high level outcomes. They see our department level report outs. They hear very transparently the things that we're doing well on, the things that we're not doing well on. And they have a voice in those committees to talk about their own experiences, or how, from the consumer's experience, what they feel like we need to do more, better, or differently to influence care and outcomes. I also implemented the daily measures of success at a previous organization where I served as a nurse executive. And certainly over the course of that time, since it's new here, we had matured pretty significantly over the course of about 18 months from implementation to the point of what I'm about to tell you. We did our morning safety briefs at those boards and had the same conversation about, did we win the day? Did we lose the day? And at the point where we had matured over the course of that 18 months, there were patients, if they were ambulatory, the nursing leader would pull the patients out of the room. They would ask them, do you want to come participate in our morning safety brief? So they could hear what we were working on as a team to help them be safe and satisfied and engaged in their care. And that to me, I mean, that gave me chills the first time I saw it, because that to me was high level engagement at every point that we needed to hit. We had interprofessional rounds in the morning, so you had all members of the care team there. But when we recognize that the patient is the most important part of the interprofessional care team, we have arrived.
I have a question. Yes, Deborah alluded to it with the interaction and engagement from the community, family members, and you touched on it as well, Dr. Seymour, with regard to the patient or the individuals that we serve being a part of the process. I often wonder, what impact the patients have on drawing interprofessional teams together. I mean, at times in systems of care, everyone's branched in different areas. I see it when I work long-term care, the patient actually brought our teams together. Whether we wanted to or not, the engagement, the patient was the actual glue in it all. Do you guys see that, feel that in your arena?
I think we do to a small degree. Again, I think as we mature in our journey for process improvement, we need to continue to press towards the patient, always being the center of that and being the most important part of the interprofessional team. And not just for their own goals of care, but for the global goals of care. Like we've talked about, how do we keep patients safe from falls? How do we prevent infections? How do we make sure that our customer experience is what it needs to be? And so I feel confident we will get to that place, but it is certainly a culture shift and it takes some time to get there. I will tell you, I do think in this particular community, we are at an advantage because it is so small. I see things like this, you would think it would be the opposite, but I see things like this accelerate very quickly, just because there is such a strong investment and tie with the community, unlike anything I've ever seen. And so I feel like we'll get there very quickly.
Awesome. I have a follow-up question as well. You talked about some of the data and information that you guys use to inform your decisions of how to make things better. When you look at the numbers of CMS data, of course, driven, how does that impact the team morale? What does that do for the interprofessional teams? I mean, we hear things about numbers don't tell it all, right? Positive numbers, higher numbers may seem better, 100% satisfaction guaranteed type. But what impact does those numbers have on you guys at your facility and in professional teams when you're looking at those reports and data?
Yeah, I think, again, it's important to always go back to the story. We also talk a lot about finding the sweet spot. You know, when you talk about process improvement, it's really not about getting to 100%. It's about finding the sweet spot. What are those upper and lower limits where you really need to have control inside of that sweet spot to maximize the effort of your staff and maximize the outcome. So when we talk about some things, there are some things obviously that need to be either always or never events. Infections are a never event. We will never waver from that. But, you know, if you think about something like patient experience, where we know that the sweet spot is right about between 80 and 86% of a top box score gets you to a top decile patient experience. I think that helps alleviate some of that anxiety, that there's not a press for perfection, and we understand that there are always going to be some outliers in some of those cases, but you got to have a good grasp of the data and understand how to explain that sweet spot and give your staff some comfort, and then always go back to the story. We're working on bedside shift report compliance right now and mastery level with that. So I tell a personal story about my son who had an appendectomy at Camp Lejeune and called me the next morning and said, I'm in the ICU. And I'm like, what? How do you go from a simple appendectomy to being in the ICU? And I said, did 2 nurses come in and talk about what's going to happen with you for the day? And he said, I haven't seen anybody. You know, so every morning when we talk about bedside shift report and mastery level, I said, don't let somebody's son call them and say, I've had an appendectomy and I'm in the ICU. So you got to have these anchors for people to go back to that you can reference very quickly. So it recalls to their mind, this affects somebody on a personal and a human level. This isn't just about data on a spreadsheet or a graph that we have hanging in the department.
It's that thing of that numbers are important, but stories and people make the difference. So, well, thank you. This has been amazing. Is there any other, before we wrap up, are there any other questions that we have to ask Dr. Seymour? And if not, we want to thank Dr. Seymour for this excellent presentation, for her knowledge and for her stories, for all of the experience that she shared tonight. I know I learned a lot, and so I assume that the audience has definitely learned as well. We want to thank the audience for participating and for joining us, and we invite you to join us again next month, April 28th at 7 p.m. Eastern Time for our speaker, who again it's the role of spirituality and our human connection with the Vice President of Mission and Integration and Spiritual Care at Adventist Healthcare, who's Ann Rhoda. So this will again be sponsored by the School of Health Sciences, and we appreciate again just all of the experience and for the audience's willingness to learn more about interprofessional education and collaboration. So we appreciate your time, and we look forward to seeing you again in April.
Thank you.